our experience with the pediatrics. I'm a pediatrician. During the COVID season, there were not many infections, respiratory infections for them. In 2021 onward, there were many cases of respiratory syncytial virus infections started coming with the typical manifestations, especially in European area. And later, the 21-22 onwards, we also started getting these respiratory syncytial virus infections. That again, so far unheard of manifestation, more of febrile seizures, croup-like presentation, atypical presentation, better. And once this COVID is over in 2022, maybe the second half onwards, this year, when the school is opening and all, many cases of respiratory infections which were not, which found it difficult, long duration, difficult to control, and many cases of multiplex PCR were done. We had adenovirus responsible, Boca virus responsible, RSV responsible, and they were all lasting duration more than 10 days. So I think this respiratory syncytial virus is coming up even in the adult and geriatric group also. And recently in the geriatric group, the vaccine has come, and in the pregnant ladies that is being recommended because that will give protection to the up to 6 months babies. So RSV vaccine has come for the adults, recommendation not for the kids. That's but I think the adeno and RSV also need to be considered when you are getting more of these viral infections. The other thing, the recent, both of you pointed out the pets. More and more of exotic types of pets are being kept, snakes, other things, and pet markets or shops are also a fashion nowadays. So we need to consider and get the history. They may not be giving the history of this sort of pets. About the one important thing, I heard the netto stock also. Netto stock actually would have benefited postgraduates rather than the senior people and the IMA members. Postgraduates and DM candidates would have been benefited by, I think, you should be giving these talks to the postgraduates also. All the pediatricians, the pulmonologists, and the general physicians. Because it's a very high level things, very difficult to remember this, and that's why. When I talk this thing, the postgraduates should be made to use the temperature chart for the both type of prolonged fevers. They are not doing it. So that is the time-tested first line method for the prolonged fevers. And that should be meticulously done. It's not only the temperature pattern, that should be correlated with the pulse rate, the respiratory rate, and they should be asked to write the remarks day-wise. Which drug is added on this day? What was the clinical finding which happened on this day? There was a rash which happened. All these things, so that this is a very good method for the pointer maybe for the fever analysis. The last thing, guidelines sometimes may misleading. And when I heard Sheila Madam's talk, Madam also is not convinced about the doxycycline. During this COVID scenario, all of us were telling this is having antiviral activity. Many drugs were used and all thrown out. Now, maybe in a CDC or WHO, whoever is coming with a guideline, which definitely we should not be following. Because the doxycycline definitely won't be practically useful. If we give a message in the general population, maybe that is one of the widest used and misused drug, azithromycin macrolide group and the doxycycline. And even I think it's not, maybe personal thing, should we continue the prophylactic usage of the doxycycline for the leptospira? It should be something else. On one side, we talk about the antibiotic stewardship. The other side, a lot of guidelines misleading. So doxycycline, I think, should again be used with some this thing, restriction. Thank you.
we get a lot of PUs and we take a history and all. So when you speak about all these things, we don't get, finally we end up with nothing. So at what point would you start about the so-called empirical, anyway, RDCP is not telling empirical ATT, clinically suspected. So to what extent would you evaluate for tuberculosis in PO patients if they don't have any localizing particular clinical examination findings, history or nothing?
So nowadays there is no empirical ATT. You can't say that. You have to say that clinically diagnosed or clinically diagnosed tuberculosis. And when to start ATT, that depends upon the physician. You must rule out all the other causes, especially malignancies, lymphomas that can present or simulate tuberculosis. So by available investigations including the bone marrow, PET CT, and with PET CT, if something is there, you have to take biopsy from that. And if nothing is there, you explain to the patient and the bystanders, and then you may start on clinically suspected tuberculosis. And you may wait for 1 month for the response, but as Radha told, the response took more time than that. But I think if the tuberculosis is not there, usually the adverse effects of the drugs are more common. We are starting on clinically suspected tuberculosis. If it is tuberculosis, okay, there won't be much adverse effects. But if it's not tuberculosis, a patient is going to have jaundice or liver involvement due to the drugs. That's what we see commonly.
About what Purushothaman sir said, we are seeing a lot of respiratory problems in the post-COVID era. People who never had asthma, never had a wheeze, they all are coming back with recurrent episodes of wheezing. So probably this COVID is an immune changer infection. We do not know. Sir.
Now, post-COVID state, many people come to you with a cough and asthma is reactivated. Now, one patient was treated like that. So when the patient came to me, when I examined, patient had a gland here. So I thought maybe tuberculosis or something else. Biopsy done, it was Hodgkin's. So a lot of immunological mechanisms are coming. So most important thing is take the clinical thing, think of common things, think of also uncommon things. So this biopsy proved to be Hodgkin's. So many things are happening in the immunological scenario.
So just 1 or 2 points to add. As Purushothaman sir had told, RSV cases are on the rise. There might be some amount of bias also, I would say, because now we are having PCR everywhere. So these things come up from PCR, multiplex PCRs. So when COVID came, PCR labs were set up everywhere. And now after COVID has gone, we are using this for diagnosing various viruses. So these things gets picked up. Earlier also we might have been labeling this as, okay, this is a case of viral fever or viral pneumonia. And nowadays the exact name of the virus we are getting nowadays. So that's why RSV, adenoboca virus, these things are on the rise. And just a comment regarding what Rajesh sir told, regarding empirical ATT or clinically diagnosed TB, nowadays we are not that much restricted because we can investigate the people. TB is not something that will just run through the blood to cause fever. It will affect some organ. You take a CT scan from the neck, chest and abdomen. If it is TB is affecting anywhere, you might get some amount of necrotic lymph nodes or some bowel thickening. Some these evidence might be seen. And meningitis usually comes with the clinical features. So PET scan, as Sharma sir was telling earlier, PET scan would be a good investigation. You see for the SUV max and you can get that. If PET is not affordable for that patient, you try to get a CT chest abdomen so that at least chest and abdominal TB will be ruled out. Rather than starting ATT empirically, you can try attempting this. And now the other diagnostics are also good because Gene Expert has a good sensitivity in many places. You get some point of infectivity, you try to aspirate a sample and send for Gene Expert or maybe line probe assay. So these investigations are better nowadays. So try to investigate, reach a diagnose and treat rather than empirically putting more patients on ATT.
Okay. Just a question on malaria parasite. What is ideal time to take the peripheral smear for malaria parasite? Very often it is done when the patient has got spike in temperature. What is the opinion of the experts?
So I would say that the parasite would be present in the blood and you can check it at any time.
What have been traditionally taught by Professor Beldaman Nair sir, pathology, because when there is a rupture, that is followed by the fever. So when there is a fever, either chills, already the rupture would have happened. So what have been taught to us is that you should take it prior to the expected fever spike, if there is a cyclical pattern. So if it is happening at 12 o'clock, you should do it at 10 o'clock or 8 o'clock. But on the other hand, cyclical pattern is not established. Particularly in falciparum malaria, you are advised to take it 6th hourly or multiple times. So somewhere you will step. That is what I have been taught. Maybe now it has changed.
Regarding general physicians, fungal infections are a gray area for most of them. So when we treat pneumonias in ICU and other infections, whether there is any clue from the history or any clinical examination towards fungal. Nowadays, bacterial infection and typical viral infections, we are dealing well with all the investigations. Fungal infections, fungal pneumonias, and atypical viral infections, it's still a gray area for almost all the physicians. Any clue in the history or examination which will clinch to some viral fungal infections?
So regarding fungal infection, there are a few dictums. So you see Candida in a sputum sample. Candida is not something that is known to cause pneumonia in normal people. So that would mostly be a contaminant from the oral cavity. So for your take-home message would be Candida pneumonia is not an entity in common people. So anytime you see Candida in a sputum sample, there is no need to keep on giving fluconazole. So that is one thing. And regarding how to diagnose pneumonia, for fungal infection there are definite criteria. I would say there are criteria like URTC, MSG. So all these criteria, it would be a combination of clinical and microbiological things. So it is not just about the hyphae. So clinical would be if the patient is having any immunocompromised status, patient is on a high dose corticosteroid, a dose of corticosteroid more than 20 milligram, patient is on chemotherapy, patient is a post-transplant patient is on ibrutinib. So these are some things where things like aspergillus could come. You suspect this when there are bilateral infiltrates or if there is a cavitary lesion. Cavitary lesions are more consistent with fungal infection. Halo sign, as was shown in one of the previous slides. Halo sign or reverse halo sign. If some radiologists report these things, even though the specificity for aspergillus is lower, this might be a clue that this could be a possible fungal infection also. And if you ask me if there are any blood tests to diagnose fungal infection, yes, we have blood tests also. So there is something called as galactomannan, serum galactomannan test, which is somewhat sensitive for diagnosing aspergillosis. So galactomannan you do for aspergillosis. Then there is a pan-fungal marker which could be positive in most fungal infection, that is called as beta-D-glucan, which would be positive in infections like Candida, Aspergillus, etc. except mucormycosis. Mucormycosis, beta-D-glucan will be negative. Cryptococcus also it would be negative. Rest of the fungal infection, beta-D-glucan would be positive. Only problem is that the cost is high. Galactomannan you try to send, the cost is around 5,000 plus. Beta-D-glucan the cost is somewhere around 10,000 to 15,000. So if the patient is in ICU, you are not getting a proper diagnosis. Always the numbers are actually very high. So in Indian ICUs, I would say the rate would be around 10 to 15% of the pneumonias, not resolving pneumonia would be fungal infection. Suspicion is high, patient is immunocompromised, patient is multiple hospital admission, try to send for investigation like galactomannan. Always CT scan is a very good imaging investigation rather than a chest X-ray for fungal infection. Thank you.
Thank you. Rationale of using oseltamivir in common viral LRTIs, like in physicians used to use oseltamivir left and right. So there is any rationale, any evidence for using oseltamivir in viral LRTIs?
If the patient is immunocompetent, no other comorbidities, even if we are detecting influenza positivity by PCR, you can leave the patient. But any of the comorbidities or immunocompromised individual or elderly individual, you can start on oseltamivir. But if there is without PCR, we can give. If somebody else in the family is diagnosed to have influenza by PCR. Okay. So there is no harm in giving oseltamivir because that is useful also. And as a prophylaxis also, oseltamivir is advised.
Thank you.